infections. Again, looking at onward referral to specialist physios with expertise in SMA airway management. Following up 6 to 12 monthly, depending on the symptoms. But again, that often can be more frequent, especially if the child has or adult has complex needs. And looking at a range of techniques, and we'll come on to that in a minute. And it's really important that this can also be combined with medications to make sure we're improving airway clearance. We've tried to cover all bases. This is very much a highlights slide, and the actual document goes into quite a lot more detail about the different types of meds that we would recommend. So this comes up really small, so I'm not sure if any of you can actually read it. But essentially what it does is it talks about the different types of airway technique. It says what their action is, so like how does it help clear secretions, what the key points are, and then what precautions should be taken in those situations. And it goes through everything from suctioning to cough assist to high frequency oscillation. So it covers the full spectrum of treatments, hopefully. And then we're moving on to acute management. So how should it look like if you end up in A&E and you're not in a main centre who knows how to look after SMA patients? So individualised care plans should be in place for the most at-risk patients. When you appear in A&E, they should be contacting the Respiratory and Neuromuscular centre that look after that patient. Admissions, as we know, can be planned or very unexpected. And in both circumstances, we're still looking at acute management. We really advocate for holistic care and a holistic approach within the multidisciplinary team. And in any situation where the child has appeared with respiratory complications, there should always be an urgent respiratory physio review. We try to avoid oxygen in isolation, and that obviously there are times where kids will end up on oxygen, but we are trying to encourage people to combine that with ventilation strategies. I can hear Toy Story, which is really distracting, I'm just saying. I can hear Woody in my right ear. Antibiotics based on sputum cultures when possible, and we're recommending that all patients should have a minimum of 7 days, but extending that to at least 14 days if they're still symptomatic. And again, progress in ventilation if needed. So what that means is you might start on baseline settings that you're on all the time, but then be aware that there are, honestly, don't worry, it's fine. I might just go and watch it in a minute. And then progressing to 6 settings, or sometimes if you're really unwell, then you need to be elevated to more unwell settings. So it's having the awareness that ventilation can change. It doesn't always need to result in intubation. If patients are admitted, then we advocate for discharge planning from the earliest point in that admission. We don't want to get a week down the line, everyone's feeling much better, but we still have no idea how to get you home. So we want to make sure that from the day one, we're starting to think about what your exit out of hospital looks like. And if patients are intubated, then we're recommending that the extubation is planned with the MDT. And I know that some of our colleagues are guilty of 4 o'clock on a Friday afternoon is not an ideal time to extubate children with SMA. So that is definitely edging towards trying to advocate for that for patients. Advanced care plans are recommended for all patients. So if you, we also include in that parallel planning. So if you are unwell, what your options look like. And again, providing details about what to include in emergency care plans. So we try and provide our patients with a traffic light system, so they know what to do when they're well, when they're feeling a bit under the weather, and when they're unwell as well. And I hand back to Anne-Marie.
Thank you. So just in terms of where we are with this respiratory guidance, so we've drafted, we've had a first draft, and that's been out for consultation to clinical networks. And we've got our first round of feedback, and the second draft is in preparation. And if any of you would like to look at one of those drafts for us, you're very welcome, because having that sort of patient view of it is really critically useful for us. But we do recognise that the draft at the moment is very much targeted to healthcare professionals. We're hoping to have the final version of the guidance available for publication before the end of the year. We've submitted abstracts about this to various conferences to spread the word. We have already been in discussion with the British Thoracic Society, so that's the network of professionals that look after people with chest problems, and they are very keen in looking at the guidance, and having their endorsement will help us in terms of getting it out there, and hopefully will also facilitate a publication in their journal. We've also been working with NICE, which you know probably is the National Institute of Health and Clinical Excellence, and we think about them very much in terms of ratifying treatments, but they are also involved in endorsing guidance. Now, they have recognised that they can't create guidance for every area, but they are now looking at rarer disease and being able to say that, yes, we believe this guidance is of a standard that can be, if you like, they call it curated. So we've been working with NICE as well to sort of improve the reach of the documentation. And we're now at the process of thinking about the family-friendly guidance. And it needs to make sure that all of this guidance is relevant, it's accessible, and it's comprehensive. So again, your feedback on what that looks like would be very helpful. This is really if you've got questions, but the same thing comes up through all the talks. So I don't know. Yeah, so should we leave that? So I'm going to pass over to Robert.
Thank you. I'll spend a bit of time explaining the content of the spinal management recommendations. There's a poster there where you can see the process and where we're up to. Pretty much in a nutshell, we are consulting healthcare professionals, and we had a round of sitting with some patient representatives already, but we will welcome any further feedback. So if you please complete the survey that has been mentioned, that will be extremely helpful. So we did this together. This is the list of professionals that were involved. These include patient representatives, as I said, but also spinal surgeons and clinicians, neuromuscular clinicians with a pediatric and adult background, orthotists, and then also physiotherapists with both pediatric and adult background. The way we define the guidelines is pretty much mimicking the current standards of care, and they do have a set of, so we basically decided what we needed to add or update from the standards of care due to the new relevant evidence, but also to shift away from the clear bias that the current standards of care have towards the pediatric population. So we've tried to kind of update these different aspects. And we stratified in having some general guidelines, something that applies to everybody in terms of assessment and management, both conservative management, spinal braces, etc., and surgical management. And then we also made a set of recommendations on assessment and management for each specific functional type, non-sitters, sitters, and walkers. What I'm going to be going through today is basically a summary or highlights of the main points that we've added to start kind of disseminating what the results look like. In terms of general guidelines, what it was in the standards of care was talking about every 6 months, again, mainly focusing on the pediatric population. So the new evidence has helped us to understand what's the impact of scoliosis. So there's new publications that highlight the impact on lung function of scoliosis, but also the impact on motor function. We've added that. And we added the consideration that in the case of adults or older children, that they have more stabilized state of the disease, it could be considered to move into the 12-month review. Then the other big aspect that we've updated is the criteria or the main points that should be assessed to monitor progression of scoliosis. This is the old flow chart, and this is the new flow chart. Basically, the old flow chart was talking mainly around criteria of spinal X-ray, certain degrees triggered certain, let's say, actions or type of follow-up. What we've done is highlight that the need of the clinical examination of the spine, again, every 6 months or 12 months for pediatric and adult patients, And what should be assessed or taken into consideration for the decision-making process is flexibility. How flexible is the back? The degree of curvature, if there's a certain amount of degrees, how big is the curvature? The presence of pain, and all these complemented, of course, with an X-ray. And based on all these criteria, the decision-making process is if the back is fully flexible, there's no presence of pain, and the degree of curvatures is below 15 to 20 degrees, we would continue to monitor. There's slight exceptions here, but we'll talk about them later on. So back fully flexible, no issues to fully correct the back, no pain. Let's wait and see. The second scenario is the back is not fully correctable. There's presence of pain. There's higher degree of curvature. Then we will suggest the start of the use of a spinal brace, and of course continue to monitor. And then this is important because the standards of care talk about above 50 degrees, and this is probably one of the most important words in the whole standards of care related to spine is discuss surgery. It doesn't mean that everybody that has more than 50 degrees should have surgery. The discussions around surgery should start, and we'll talk about the criteria in a bit. There's a lot of writing in here, but I think the main points here is there's no supportive evidence. We don't know which braces are better than others. We might have a clinical impression, but we are not in a position to include specific recommendations on any type of brace as we stand here. It might be in the future, and it's definitely one of the pieces of research that we would like to develop in the future. That's one of the key priorities, which brace is better than other. We do also know that there's diverse access in the UK. Not everybody is doing the same, and we're very grateful of SMA UK that did the survey. But at the same time, or more recently, Lian's paper came out and was a very good way to prove that the access to different kind of braces and techniques to manage spines was present in the country. So we listed that as evidence. And then we are also aware of the impact of braces. We acknowledge that it's not an easy intervention to take on as an individual, but also as a family. There's challenges, and we wanted to acknowledge that it's not straightforward. It's not pretty plum that you take it. There's a lot of commitment, a lot of effort that goes in it. And we wanted to also make quite clear that there's no evidence that suggests that the use of Lycra to manage spines in SMA is efficient. It works or makes a difference for our patients. So we don't have any means to support that Lycra makes a difference in managing spines. Lycra might have a role in SMA. I'm not dismissing that, but not to manage the spines. And then we wanted to be clear in what we are aiming for. Why are we suggesting the use of a spinal braces? The braces should be a mean to manage the posture of our patients. The braces won't stop scoliosis. The braces won't reduce the likelihood of needing surgery. The braces help to keep the body of people living with SMA in the right position, and this is what we're aiming for. So with the brace on, your spine should be better aligned. And also, the use of the brace should have a limited impact on your breathing. If you have your brace on and you can't breathe, that's not right. That brace should have a limited impact on your breathing. And the benefits of bracing is that by having the back better supported, your arms should be more able. The fact that you don't need to rely on your arms to keep your sitting position, what we call prop sitting, the fact that your back is well supported, your arms are free up. We should see a better arm function, a more freedom to use your arms when your braces are on. Should facilitate also leaning forward and sideways, so there's a bit of a tilt. The spine is a block, but there's more allowance. And we expect also to have an improvement in the capacity to develop a certain degree of head control, if not already achieved. Then we do acknowledge that exercise is a very important aspect, but today we don't have evidence that any exercise has an impact on the progression of the scoliosis. We need to stand here to set the right expectations. We talk about exercise, it's very important, but there's no evidence that exercise will slow down or have an impact on the progression of the scoliosis. The aim of exercise should always be to develop support the motor development in children and to increase the levels of physical activity. And we talk at length in the previous session, but it's important to set the right expectations in terms of spine management. That's it. And there was already quite a lot in terms of surgical recommendations for the present 2018 standards of care. So there was quite a lot of recommendations, especially around age and around skeletal maturity. So the only addition that we put are the three bottom ones. There is insufficient evidence in the literature to support that spinal surgery will improve respiratory function, has many other advantages, but the surgery should not assume that the respiratory function will be improved. Currently, we don't have magnetically controlled growing rods. The magic rods had an issue. It might change in the future. There's some work going on, and there's one particular model that seems to be getting through. But this was a main difference because there's growth-friendly materials, but they are not magnetically controlled rods. And also the decision on instruments should be tailored to the patient based on spinal curvature, age, skeletal maturity, and anesthetic risk. And of course, the need of in-vertical access should be considered, but this was already part of the standards of care. And I think from here onwards is quite straightforward. There is more evidence about the impact of scoliosis in the natural history in type 1s and type 2s. We do know better about the progression of a scoliosis. There's a big court, a paper of the big court in the Netherlands, so that puts some light. And as we said, the only major issues for non-sitters is the suggestion of assessment over the period of 12 months instead of 6 months, and also acknowledge that for adult population or more stable population, the use of the brace might not be the election. Having supported seating or molded seating might be enough in this population. For the assessment, examination, and we highlight the value of the X-rays outside of the brace to see the impact of gravity in the back of the patients as a main source of objective information through the X-ray. For sitters, again, the same recommendation, 12 months, the value of X-rays outside of the brace. And we do acknowledge also that the in-brace X-rays might have a value to see the impact, have a capacity to compare how your back looks without the brace and with the brace might give us a clue on the first question that we were talking about, which braces are more effective to manage spine deformities. So we acknowledge that as well. And for walkers, again, the same thing, 6 months, 12 months follow up in terms of assessment. In terms of management intervention, and this is potentially the consideration that escapes that flowchart that we talked at the beginning, it is acknowledged that there's with disease-modifying treatments, the increased survival in especially the most severe phenotype is increasing, and we do see more and more children have this kyphotic, the curve, exactly that one, yeah, the curve back. So considering use of bracing in the absence of pure scoliosis, so lateral deviation of your back, but also to manage the kyphosis, the curvature, the crouch position is something to consider. In the non-sitters, it might be helpful to have additional head support if head control is not achieved. And the early introduction of the brace might be also considered for weaker patients. In terms of recommendation, when to wear the brace, the recommendation is to wear the brace always that gravity gets through the back, what we call that, a upright position, sitting in the standard, any positions, sitting in the chair, always that the back is upright. The exception of this is if they are doing any exercise, any physio sessions, anything that requires the measure mobility as possible, the brace can be removed. But as a rule of thumb, every time that the back is upright, to have the brace on. This is only the key recommendations for sitters. Again, the use of the brace in any time that they're sitting in a bright position or standing, supported standing, etc. We acknowledge that in the walker group, this might apply, but also there are many compensations that the brace might interfere when there's assisted, supported walking or independent walking. There's a lot of compensations that are going on that the brace might get on the way. So it's more kind of flexible to consider when there's an upright position that needs to be supported to use it. I think, and these are the different levels of evidence that we use and the reference that we added for these, and pretty much that's I think what I wanted to say today. And I pass it over to Giovanni. Thank you.
So another of the working groups that has been selected to start to work on updating the standard of care is HIPS, and then this is a burning topic, especially among, I would say, new families of type 1 babies, because in the past, when there was no disease-modifying therapy, somehow there was consensus that this was a no-way, zone, a no-go zone, like don't touch the hips of an SMA patients because we know that they are going to dislocate. Usually they're not painful. There is nothing that you can do to stop it. And the fact that they dislocate not necessarily will affect functioning, the things that they can be able to do. Now, the history is changing because these patients are receiving treatment. And actually, we don't know the new natural history of the hip displacement. So this is one of the big gap that we have in the knowledge, the evidence, the concept of generating evidence that we have been discussing about, over today many times. So we don't know if there is any benefit in preventing dislocation, if there is any way to prevent dislocation, and if treating, hip displacement would have any impact, any benefit on the long term, in allowing additional acquisition of milestones in patients and so on. So this working group is working on trying to generate this recommendation, this evidence, and there is essentially, I would say, three big streams. One is the conservative management, so what we can do to prevent or possibly prevent, or if there is anything that we can do to prevent hip dislocation. Where is the evidence so far about that? And there is very little in the literature, very little limited experience. So there is a working group, mostly involving physiotherapists, as you see, neuromuscular physiotherapists or orthopedic physiotherapists, community physiotherapists. This is trying to see if there is any evidence published and which are the main aspects that we should look at, and they have already had a number of meetings looking at this. We should mention that there is already some model, published there, that is all the work that has been done in cerebral palsy. So many of these physiotherapists have a lot of experience in the community or in the hospital settings in managing cerebral palsy. And now there is evidence about preventing dislocation, what needs to be done. There is a registry to collect the data. So somehow they are trying to see what we can pick up, from this evidence, from these registries that have already published something on cerebral palsy, and see how all this work can be adapted to SMA. As you see, there is a lot of discussion about Is there any benefit in a conservative intervention? Is there any need to prioritize, way to promote to prevent some hip dislocation using a specific technique or specific tools or specific orthosis? So this is the kind of work that they are doing in terms of conservative management, identifying what are the patients that should be referred for additional investigation, so for the discussion with the surgeons, so at some point when we need to start discussing with the surgeon if there is any need to go ahead with surgery and so on. So the second stream is we need to develop the knowledge about the new natural history. So we need to collect the data. We have talked about this several times. So we need to adapt the existing registry, including new aspects that relate to hip displacements. So it's not only the radiographical appearance of the hips, but it's also what are the segments that we need to assess if they are weak, if there is any contracture specific that we need to register, and monitor and see what is the trajectory. So data collection will also be important, and now there is all this work trying to identify, okay, which is the minimum data set that we should try to collect in a prospective way so that we can build up the new natural history of this condition, and we can be able to say, this is the, the kind of approach that we all need to follow. And then there is the third work stream, that is the orthopedic management, where somehow there is already an advanced work that has been done, mainly starting from the conversation that between Gosh and Evelina we have been having for some time, and we have had already a couple of workshops that have been extended also to other surgeons and colleagues across the country, and there will be a new workshop next month that essentially wants to facilitate, the harmonization of the approach. We don't want that, we know that families are very connected. We don't want that they say, oh, at Evelina they are doing this, why they are not doing this in Leeds, why they are not doing this in Newcastle or whatever. So it's very important that we try to harmonize the approach, and we have brought the surgeon together, the neuromuscular together. I think the huge shift, I must say, has been having the possibility to have everyone in the same room, because of course probably the neuromuscular consultants at some point were the gatekeepers to say when we need to go further, to the surgeon, to discuss surgery and so on. Now we are trying to be all in the same room: physiotherapist, neuromuscular consultant, orthopedic surgeon, orthopedic physiotherapist, to say, let's discuss collectively the cases. Let's see what are the patients that could potentially benefit. Let's see what we can do. And there has already been some effort in this sense. There has been like a survey and a work to develop at least some very general statements on which there was consensus. So this is, it's called a Delphi process, where you basically start from some statements, agreed statements, and then you refine them in a number of rounds, try to achieve the most of the consensus. And these are basically the process. Several participants across the different specialties were involved, and we had 2 rounds of survey. And these are the 16 orthopedic management statements that have been agreed. So first of all, as you see, there has been a huge shift, meaning that now there is, discussion or consideration about the fact that an effort should be made to prevent hip dislocation, especially in the new phenotypes, in the babies who have been treated early and then can achieve new milestones. It's not a sort of a taboo that this is not something that should be moved forward. It has been agreed also that we need probably to monitor more closely also in terms of X-ray and trying potentially to have a sort of baseline quite early, similar to, as I mentioned, the world of the cerebral palsy. They start X-raying patients quite early. So, around the age of 1 year or so, now there has been this consensus of saying, let's try to have at least a baseline to see what's happening. And of course, to minimize radiations, with time, this can be adjusted depending on how the situation of the patient evolve. There are some, specific data about the X-ray that the surgeon were suggesting to collect. I'm not going into details about that. Another key concept was, let's try to avoid that one family goes to a surgeon and another family goes to another surgeon. They receive conflicting, reports or feedback and so on, or, depending on the site that you are going to, you may be advised in one way or the other. Let's try to have MDT, where all the different professionals are involved. Let's try to discuss not only at the site level, but at a more regional level. So what we are doing now is that, for example, all the London area or South area, because now we are expanding also to other towns, in Southampton or Brighton and so on. Let's try to discuss cases all together so that there could be a sort of agreement. Could be in the best interest of this child to go for surgery, yes or no, or to have some option, yes or no. And another aspect that I wanted to mention was also the agreement to try to see if there could be some benefit in having microsurgery. So there is a lot of conversation now about guided growth. That is an approach that has already been used in cerebral palsy that is less invasive than the big surgery on hip reconstruction and so on. There is no evidence in SMA yet. This is something that we want to try to build evidence on, but it's a moving target, we still don't know. So you may have heard that some patients have been treated with this approach. There is agreement that could be an option to consider, but the evidence is still limited. So it's an ongoing process, again, across the 3 working streams. Another aspect will be, what type of rehabilitation or physiotherapy we need to do after the surgery, and it's very important to ensure that these resources are in place if a child has been considered for surgery and so on. This is the working group of people, but all across the countries there are many people that are coming on board, and there is a poster about the surgical statements, but the process of developing the whole working group statements is ongoing, and we hope to finish the work in the next few months. The next one.
So I hope that's given you a bit of a flavour about where we are at the moment and the sort of work we're doing to try and bring together more information and consensus about what best practice looks like. If you've got any questions specifically about anything that we've discussed today, then please scan the code and Portia will monitor.
Or pop your hand up. That's fine too.
If you've got more generic questions, we can try and help you with them. Obviously, this is a rolling project, so we really want to get these 3 elements complete and out there, and then start to work on the next phase, and then take on more and show people who are going to fund us to do this that it's a very beneficial thing. Any questions, anybody?
Hello. So once you gave the timeline of when the first one's going to be going out, how long do you expect the uptake of the specialist centres to actually be rolling it out, and you're actually seeing it in our appointments and stuff like that?
So, I think that we're hoping that the respiratory guidance will be ready for kind of clinical presentation by the end of this year. And I would hope that the sort of family-friendly versions won't be too far behind. But what we found in other areas is that you start these things and then you discover that actually you need to write something a little bit more about ventilation, or you might need to do something else. I think it's about disseminating them. So I think it's if we know that they've been published, they'll be disseminated through the REACH networks. We'll try and present them at other conferences, publish them in medical journals, but also make sure that you as people living with SMA have them. And so that hopefully should prompt people to think about it. But it is something we're thinking about. I don't know if anyone else got any comments, Robert?
No, I just wanted to add that the guidelines are the first step to get care implemented. And we have some kind of guidelines already in place, and I can tell you thinking about the adult perspective, that these are not implemented and they've been published for many, many years. So it doesn't guarantee that these recommendations, but it's certainly the first step to advocate for all patients with SMA to have access to the relevant care. There will be many, yeah.
I mean, I think that, you know, we recognise that we're living in difficult times financially for healthcare provision, and there's so much overlap, isn't there, between healthcare and social care and education and all these things that you're battling with on a daily basis. I mean, I think that we don't want to come up with just a wish list. We want to come up with guidance that is applicable, and we might need to think about that. How do we implement that? And that's why the interaction between REACH and the SMA Care Project is really important, because as Giovanni says, you know, maybe we need a network within each region so that there is a place where you can come and you can discuss your x-rays of somebody who's got a back problem or a hip problem or whatever it might be, whether this person should have a ventilator, and that there's a forum where you can do that so people can share in the expertise and it can be disseminated. But I mean, it won't be magic, but at least it's a start, I think.
I've got a question here for spine management. Is the plan that the clinical examination would include an EOS every 6 months for children to evaluate progression, as today many centres do not offer such scans?
I didn't hear that, but
EOS scans, are they going to be in the recommendations for spines?
So we, as I said, we will put these recommendations through, and this doesn't mean that every single centre will align with these. What we definitely feel like is a no-go is going below this clinical examination and the guidance on a specific X-ray. That's why we weren't that prescriptive on the use of the X-rays, and it's more a clinician-driven decision. But certainly the clinical examination, checking the backs, should definitely happen.
Sticking with this, oh, I've got one hand. No.
Yeah, hi. I've got a really long question, but I'll try to split it into 3 parts. It's all about spine and bracing. So one, you mentioned that there's a lot of evidence or no evidence actually, what to do with bracing, what type of bracing is it? So how do you gather that evidence? Have you actually published the data? Do you have the data between the centers that have started bracing early, the spine surgeries delay, versus the center that don't brace early, the spine surgery happens earlier for kids? Is that one of data you have used to give those guidance? Second question will be, when you said about you recommend the out of brace x-rays, if you start bracing and we are told to wear brace as much as possible, is not in brace x-ray more important to see how much correction and how much flexibility you're getting, rather than if a kid spends most of the time in that x-ray? And lastly, Dr. Baranello mentioned about hips, and it looks great that you're gathering the data post new therapies, Zolgensma, all of that. What about spine? Because I cannot imagine that you have all that data if the new therapies has just been happened. So are you gathering that data now as well? How the gene therapy has changed your guidance?
Okay, so they're all very good points, and so far the evidence that we have is a bit what I was alluding on Leanne's papers, that the approach is diverse, and that's why this group was one of the first priorities to try to put some harmonized access to the relevant care. The way we gather evidence about the different braces is exactly what you described, trying to standardize access to braces and then see which braces are better than others, monitoring. There is an initiative in this specific topic, and we'll hopefully have more evidence. That the issue is it's very difficult in every single intervention that is care management to go to the highest level of evidence, which is the randomized control trial that we get normally the drugs approved. So what we can't do with the spinal braces is, well, we're going to leave Birmingham without braces and Manchester with braces, and let's see who does better, or put them in a randomized control trial. So gathering strong evidence about conservative management often follows a different route and is either slower, or the evidence that you're able to gather is less strong for these simple reasons. So we won't to standardize access and gather evidence about the rate of progression and different braces, and potentially this will shed some light in which braces are better than others. For the X-rays, the out-of-brace X-rays tells you something, the in-brace tells you something different. What we say in the guidelines is that the priority is that out-of-brace, because you have an understanding of how big the curvature is without support. The in-brace are helpful, but if the recommendations were stating that we need in-brace and out-brace, this is duplicating the number of radiation that we need to put. And it is a more difficult call to put in the guidelines. So we want to prioritize out-of-brace because they are the ones that tell us how unable that curvature is to resist the force of gravity to monitor the progression of scoliosis, but it's undoubtedly that the use of in-braces, and that's why we acknowledge that in the guidelines. And I forgot about the last one, sorry, the hips. Yeah.
Do you want to finish that?
Yeah, so fortunately, it's very difficult to gather data in natural history because the vast majority of patients have access. So you're absolutely right, but that's another layer of complexity that we added in gathering strong evidence about conservative management. We will do our best and we will try to standardize, but you're absolutely right that the new therapies or the arrival of different therapies adds another layer of complexity. Are they doing better because they've got soul gens more, because they've got this type of brace? But it's adding complexity, but it's not insurmountable. We'll get there, but it's just a slow and less strong evidence.
I mean, in a sense, I think what we're saying is that the care guidance is about the best practice on the basis of the evidence we have now. It doesn't mean that we can't address all the research questions, but we can highlight the things that are really important to the community and to us as healthcare professionals. But then we might need to think about developing other projects. And as you've seen on the posters, there is work going on, and it's just pulling all these work streams into something that's meaningful at the end of the day.
I've got a question from the adult cohort here. Most of us have had full spinal surgeon and have been completely discharged from any sort of spinal care after the age of 18. We've heard a lot about child-focused hip and spinal care, but what about the adults? So,
double bullet, because I'm somehow responsible of the adult network, so I fully agree that care for adult population is one of the main battles that we're working on, try to improve care for adults, but there are two factors here in spinal surgery. Surgeons do surgery, that's it. When they've done the surgery, if you overcome the infections and the peri-operational issues, they would normally discharge you, and they're very happy for us to re-refer you if there's any issues. We've got adult patients that have pain related to the screws normally at the sacroiliac joint moving and so on, and they're happy to re-refer you. But care, so spinal management after surgery is often no care, as in considering that the problem is fixed or kind of stabilized forever. So it's not uncommon to get discharged. So I wouldn't like to send the message that you need to be followed up by the spinal surgeon or orthopedic team after you had the surgery. But what is certain that if it's not the case or if there's any issues, you should receive that check out in your adult services and be re-referred if there's any particular issues.
I mean, sorry, just butting in again.
No.
I think that this is why we need this kind of guidance, because you're back in your SMA centre then. So we want to be able to define what your follow-up for spine or hip management should be, whether you've had surgery or not. What are the important things? I mean, I'm sure many people in this room who've been through surgery haven't had the easiest course. And this is one of the reasons we'd like you to fill in the survey, which is advertised on many doors around the place, because that's the question we're asking is, what's your follow-up like afterwards? Have you had problems with pain? Was your recovery as you were told it should be, or was it different? So I think we want people to have guidelines about how we should be managing your spine, even if it's post-surgery within your SMA clinic. What should people be doing within your SMA clinic? What should we be doing about your hips, whether they've been operated or not?
And someone said, will spine x-rays still be recommended for treated children reaching motor milestones and very mobile young people with SMA3?
Yeah, so this is a bit unofficial information, but with our colleagues in US and their experience, gene therapy treated children do still develop scoliosis despite progressing in their motor development, despite still gaining the ability to sit and walk, despite following a more normalized motor development, they do still develop scoliosis. So we do expect that this issue, unfortunately, is not going to disappear completely. There's also always better and worse responders, and the experience from our colleagues in the US is that scoliosis is still a thing despite gene therapy and pre-symptomatic and achieving the ability to walk.
You've covered spines and hips. What about knees whilst I walk?
Yeah.
Oh, you've got one. Sorry, I'm carried away.
Hi. I'm Min Ong. I'm a neurologist in Sheffield Children's Hospital, and I guess I would like to just add some things to the comments on spines. So what Robert has mentioned was entirely true. We need some sort of standards in terms of x-rays, because currently everyone's doing x-rays at different times. But with the standards of care, potentially we can then look into different techniques of managing spines, and we are trying it together with the British spinal surgeons. We are trying to develop a study that will cover the nation and work together into looking into what management is most useful in different cohorts of SMA children at what time, and also looking into the risk of spinal surgery and whether there are actually any complications from that. So we are currently developing this, and hopefully we will then be able to produce the evidence that we need in a very short time, particularly if many centers participate in this. So we anticipate this will potentially be a 2-year project, but I think we will be able to get some evidence to support management either way, and to determine what's best use of money well spent to manage spines. Hope that answers.
Yeah, this is sorry Ming, I didn't introduce you, but this is the project that I was talking about, that there are ongoing initiatives to gather evidence about different spinal braces and interventions.
Yes.
I'm not sure who this is directed to, but on one of the early slides it talked about horizon planning and looking at what other countries are doing and other approaches to care. What does that actually look like, given quite a few families are travelling abroad for things like orthosis, travelling to different parts of the UK as well for bracing and things like that. So what does horizon planning look like, and how do you intend to use that information?
So, I think it's really referring to what we've said. It's about horizon scanning. When I was referring to that, was thinking kind of probably outside the UK. We're hoping that this project has engaged clinical networks within the UK in the hope that we're kind of bringing together. I think that it's really important sometimes just to say that there is no evidence, because that's the situation. Because I think it must be a terrible burden as an individual living with SMA to think you're not doing the right thing because somebody somewhere has had an operation for this or has been hung upside down on a bar. Not speaking about any particular colleagues, but it's really hard. And sometimes just saying that there's no evidence that this is better than anything else at the moment is important, but this is how we're going to gather the evidence. These are the areas that where there's uncertainty, and this is how this network in the UK proposes to bring together these different work streams and gather some information to inform you as parents or people living with SMA and us as clinicians as to what the right thing to do is, and that's why we need it. And that's why I want to bring it together. But we know that, for example, the Cure SMA might be doing some work on an area, or SMA Europe might be doing it. And what we don't want to do is, there's no point in reinventing the wheel. If somebody's already done a piece of work on an area, then we want to take it and bring it to us to use it.
And that also goes back to the point of the role of SMA Reach Adult and Pediatric Network in gathering this first level of, who has a spinal brace, talking about the spinal management, who has a spinal brace, who doesn't, which type of spinal brace, even knowing this, even able to put some black and white evidence of what's the current access on these type of interventions is a good starting point.
The trouble with many clinical guidelines is that they take a huge amount of effort from the enthusiasts and then gather dust because they have no teeth. And I'm just wondering what your plans are to see that this is implemented. And in particular, have you got relationships with NICE, who obviously have more teeth than many?
So I've maybe brushed over that very quickly, but we've been in discussion with NICE. So NICE have now kind of reviewed how they are managing guidelines. So they've come up with these 6 C's, and the first C is them creating guidance, but they're not particularly focused on doing that kind of amount of work for an area that they perceive to be a rare disease. But they have developed a system of what they call curating guidance, where you can bring guidance to them and you have to bring it to them early and say, make sure that you're following the processes that they want you to follow, something called attend to. And we've already been in touch with NICE in order to sort of get their sense of whether they're happy with working with us, and they are very keen. It would be part of the rolling process, but we have been in discussion with them. I think getting the endorsement for the various networks is also important, because I think that often there's no point in us having guidance in this room. I think it is about getting it to those other centres. So it's getting things published in the intensive care unit conferences or whatever, so that you're getting to those people that you, as people living with SMA, interface with, who aren't not necessarily experts. So, we've taken a lot of inspiration, I suppose, from what's happened in Duchenne and the DMD Care project, and we've basically seen how they've made changes that have been effective and less effective. So I think that getting some kind of sense of where we are now by asking you to complete the survey, that gives us an opportunity to then maybe repeat that once the guidance is out for a couple of years and see whether it has made a difference or not, because you're absolutely right. There's no point in doing a lot of work. But I think if we don't have a minimum standard, then it's very hard to do anything that in terms of improving the situation.
So I have a follow-up question also on the implementation of the guidelines, which we've been waiting for a long time, so it's great that they're coming. So we've discussed implementation within a clinical environment, but my question is about implementation actually within a family, within a school, within a community. So we had very good example, I think, of Brompton Hospital having outreach respiratory physiotherapists teaching staff at school, teaching local well, depending on the age, that would be either school, there will be a personal assistant, there will be carers, how to use the equipment, how to manage respiratory conditions, how to manage secretions, all those things, how to write the care plans, for example, and creating bespoke plans for particular patients, children, adults. So is that something that will be a good practice, also implemented at different centres? Because I think at Brompton it worked very well. I don't know if there is an equivalent at Great Ormond Hospital or anywhere else.
So there is a huge network of respiratory pulmonologists and therapists that are all linked now through SMA Reach. And within that, we will be looking to share the SMA Care guidance, so it would then be rolled out universally throughout the UK. It is very difficult in terms of telling them how they have to implement it. So like your example of going out and teaching people, it's quite difficult to be able to do that in restrictions that the NHS has currently. So if there is the ability to go out and teach, of course, the clinicians from the tertiary centres are very happy to go and do that, but it's the ability within a restricted time. But the guidance is aimed at educating people. So by giving it to the community, by giving it to patients and families, the idea is that it will then get shared wider. And the wider we can share the guidance, the more education we can provide to the people that need it.
And I think that's exactly right. So within the recommendations for respiratory care, it says that everybody should have an individualised care plan who has had any problems with their chest. It also tells you what that should look like. So there will be that sort of nitty-gritty. And I think there's lots of ways of sharing that information, and that's where we need your help and support. But, we could do a webinar to talk about things that people can then access. We can do specific training through the REACH networks, which already exist. There's different ways of doing things depending on what we're trying to do. But what we know we won't be able to do is get a respiratory specialist physio in every unit, because if we ask for that, we won't get it. So it's how do we draw on what we've got to implement what we've agreed is a minimum standard of care, because we don't have that at the moment.
And also, I think the challenge comes when you move from specialized center to community, because if we think from other ground, and this applies for GPs and some communities specialists, the chances of one of these professionals coming across as an SMA person, let's say somebody living with SMA, are quite slim. They might encounter, and if by chance there's a professional that bumps into 2 or 3, that becomes a specialist in that community. But it's very difficult to reach or hit all these communities, especially thinking with GPs when they look at you and say, well, what are the chances? What are the chances of me getting, to come across of one of these patients are very, very slim. So often you can reach and teach to a certain extent, and the next level is to make information and training available for anybody in community that comes across of one of you, and make that connection smoother so that the information reaches them, training reaches them. But aiming to target all GPs in the UK is impossible, or reaching any. So the guidelines also aim for this, have these guidance accessible to families to say, listen, this is what I should be getting from you. Get in touch with the specialized center and find out how to do it.
Right, I have one more question. We're going to take one more, and then we'll put up the QR code for this survey that we've been talking about, which will also be emailed to you and put on WhatsApp groups until everybody's done it. Last one, and it's about spines again, I'm afraid, Robert. Says, I've gathered from the talk that neither spinal bracing nor exercise can help prevent scoliosis. Is there anything that might help?
So the appearance, I think we need to be frank and transparent about this. The appearance of a scoliosis is a result of muscles that are supposed to support your back being too weak. To date, we don't have any conservative management that can change that. What we can do is how much the consequences of this weakness compromise your daily living with postural management, but also your chances of having a more definitive solution that so far is only surgery what aims to this. What is very important to understand is that conservative management aims to provide you with a better posture, but also to take you to the point of a potential surgery in the best conditions, so the outcome of the surgery is the best that we can. There will be probably many people in the room that had surgery or had a failed surgery or had a very bad scoliosis that went out of the window of potentially being able to go through surgery. We want to prevent this situation. We want the backs to be as flexible as possible to go to surgery in a better condition. Of course, early treatment, newborn screening is the way forward, as many other aspects of SMH, to make a significant improvement in the outcome or the need of surgery. But the root of the problem, which is a weak back, it can't disappear, and that's why we don't have anything else than looking after this back to get to the best place that we can to aim for the surgery, if that makes sense.
Thank you very much. So if we just click forward a couple of slides, I think. There we go. This is the QR code to your survey. We'll leave this up here, and I think maybe give you 10 minutes back. Giles, did you want to say a little word before we finish? Big round of applause for the SMA Care UK team. Thank you so much. It was really, really interesting. Quick, yeah, just round up, and tomorrow dinner's here. Don't.
Okay, cool. I'll just go on the letter. Okay, guys, thank you so much for presenting again. You know, as having the clinicians with us all weekend is invaluable. And I know that lots of people have been speaking to them at various points as well throughout the weekend, so please still take that time to do that. Just a couple of little things. That's the formality all done for today. We now have free time. The most important bit is the bar is open at 6:30, just in the main foyer. And then we will be back in here for an early dinner for the kids around 6:30, and then 7 o'clock for a buffet meal in this room. It'll be set up at the back, and we'll have, I think we've got about 30 round tables around the room as well. So this room will get flipped back over as well. So please take time, bit of free time now, but I really, really appreciate all of your time. Are we off?
Got a live band and dancing from 8 o'clock, so please come and join us for that. It's going to be lots of fun. And in the morning, the doctors and researchers who have done the research and made these posters are going to be hanging around near their posters. So if you want to hear more about the doctors' research, then do come down to 10 o'clock in the morning, and they'll be hanging around there to talk to you. And I'm sure they'll be here dancing with us tonight as well. Thank you so much for the day. It's been fantastic. You've been great.
Great.
Sign on the door, say don't disturb this crew. Just wait a second, I'll wait to you. I feel so real, don't disturb this crew. I'm so into you.